Hello, YouTube. How's it going? It's been a minute since I did this damn thing. Since since I did this damn thing, and today I want to share with you something that has been weighing on me heavily, um, forever, which is moral dilemma, moral dilemmas. So I am. My name is Matthew Tonthat, and I am a urologist with a passion for questioning the status quo in myself, in the world around me, in urology, in life, and health. And I am a urologist with a man bun. Yes, I have a man bun. And I'm not even board certified yet. I'm serious, I'm not board certified yet. I am board eligible. Um, the difference is really only known to urologists. But so you complete medical school and you're an MD. You complete residency, which is 5 years, and then you are a urologist. And there is a board examination, like there are for many professions, and there is you can be board eligible and board certified. Our board exam is two parts. The first part is a written test, which I passed. You have to take that within, I don't know, a few months, certain amount of months of graduating. And then part two, which is the oral board, is the part that I failed last year. You pass the first part, you're board eligible. And then you pass the oral boards, the part two, then you're board certified. I'm not yet board certified because I failed it, and I get two more attempts within the next 5 years, and my next attempt is next month. So I am in the process of studying for that. And one of the things I realized in my oral board exam studying is that, and the oral board exam is basically it's a couple, it's not even super long. It's like 3 hours or less. And basically there's some more seasoned and tenured urologists will be basically asking you questions and giving you cases of clinical events, surgeries, complications, clinic follow-up, everything about urology. And it's like, what would you do hypothetically in this situation? And you have to talk through your responses and be prove that you are logical and that you are competent and that you follow the guidelines. And the guidelines is what brings me to the moral dilemma, because there are guidelines, and medicine today is very guideline based, algorithmic, to where there's in every specialty there are guidelines. Like the American Urological Association makes the guidelines for urologists, and we generally follow those guidelines. Now, the guidelines are made for they're the textbook patient. And what I've found is that in real life, most of my patients are not the textbook patient. And when I go simply by the guidelines, I often have a knotted feeling in my stomach, like this is what the guidelines say, and this is what I'm supposed to recommend the patient. However, my gut is saying this might not be the best thing for the patient, and that happens far too often. And it is the moral dilemma. It's the moral dilemma because on the one hand, I want to follow the guidelines because that is supposed to be the right thing to do. It is how you don't get sued as well, because you can fall back on the guidelines. Oh, this is what the guidelines said to do. But I don't like doing that when I don't feel like it's right in my gut. And of course, I try to communicate that to the patient, but in communicating that is the moral dilemma in and of itself, because I am having to communicate to the patient, like, this is what this is what I technically recommend, legally recommend. However, I don't know if, like, I would do the same. Something like that. Make it very clear and not clear at the same time, that and sometimes it comes across and the patient understands what I'm trying to tell them, but it does require some amount of health literacy and education, and willingness to listen, and willingness to, I guess, question. Um, and it results in, sometimes the patient gets me, but a lot of the time the patient does not quite understand what I'm trying to say, and I feel silly. So yeah, that's the moral dilemma I've come across more often than not, actually. Like, I'll give an example, a de-identified example. Let's say there's a asymptomatic microscopic hematuria. What that means is it's not causing any symptoms, and there's blood in your urine, but it's microscopic, so you cannot see it. And we get a lot of referrals for that, and that will result in us working it up. The workup commonly consists of a procedure called cystoscopy, where we go in with the camera through the hole you urinate from, take a look in the urethra and the bladder, and we're looking for any tumors, cancer, or any other potential causes of the blood in the urine. And this procedure is done in our clinic, and patients are completely awake for it. Men are laying down flat. Women are usually in stirrups. And the procedure is, you're putting a camera in someone's urethra, through the hole they pee out of while they're awake, and it's not comfortable or fun for them. And I counsel patients that there is some amount of pain with it, but not all urologists or providers do, because that's the moral dilemma. Like, it's hard to say, hey, I recommend doing this so that we can work this up, and it's gonna hurt, and it's a part of it. But that cystoscopy is a part of it. The other portion is some sort of imaging, like an ultrasound or a CT scan of the kidneys, because the bleeding can come from anywhere in the urinary tract, including the kidneys, the ureters, which are the tubes that take urine from the kidneys to the bladder, and the bladder itself, as well as the urethra. And all of that's evaluated, and that is to detect bladder cancer, which is also known as urothelial carcinoma, which is cancer. And then we have that word, cancer. However, asymptomatic microhematuria is just that. It's asymptomatic, so it's not causing any symptoms, and it is cancer. So that's why we have this workup. And the rate of finding cancer, if you have this condition, is somewhere between 1% and 3%. Very low, but we get a lot of referrals for that. And in order to meet the criteria for asymptomatic microhematuria, you only need to have 3 red blood cells per high-powered field on microscopy, which is not a lot. Many people have many other causes there are many other causes of microscopic blood in the urine, and most of them are not cancer, But when we have cancer in there as in the differential, then I, as a urologist, and I'm telling you that we do this workup in order to detect cancer, because that is what screening is. And most patients, when they hear the word cancer, they absolutely they're like, all right, whatever you recommend, doc. And then so I diagnose it, I treat it, and it's I see how that course looks, and so I get an idea for what the workup looks like, what treatment of it looks like, what it entails. And there are some patients that I see them, and what I think to myself is, I don't think that this is the best thing for this patient to even get this looked at, because especially for something like asymptomatic microhematuria. So let's say an example is let's say there's a 69-year-old male who has asymptomatic microscopic hematuria, and this was found when he went into an urgent care and had, or when he was admitted to the hospital, because he was found down because he was, because he's homeless and schizophrenic, and he fell, he was resuscitated and given a primary care physician. Somewhere in that process, urinalysis was done, and there were 20 to 40 red blood cells per high-powered field. It was in the absence of infection, so it meets the criteria for asymptomatic microscopic hematuria, and now I am seeing him in clinic. And I actually don't see him because he misses all the appointments, because he no-shows, but we keep reminding, and one of these times he makes it. So now and he's not sure why he's in clinic, and I have to tell him, well, it's because you have the blood in your urine, the microscopic blood in your urine. And he says, I don't see any blood in my urine. So, and then I say, well, it's microscopic, so you can only see it under the microscope. And you see red blood cells, and it's to detect, we recommend this workup, this procedure, cystoscopy, and a CT scan of your kidneys, to look for the source of this bleeding, and just to make sure that there's no tumors that are bladder cancer. So, and then most of the time, how it goes from here is the patient willingly goes along with whatever the recommendations are, and the recommendations are based on the guidelines. And now that's where I hit the moral dilemma, because in my gut, I'm like, man, we're going to use a lot of resources to treat, to diagnose, and to potentially treat this patient's asymptomatic condition, when I look at his social situation, otherwise, I don't think that's the best thing for him. So maybe I try to explain that to him, and he's not able to understand, because all he heard was cancer. So let's set him up for a cystoscopy, and we'll get a CT urogram. And then on the cystoscopy, say we don't find anything. On the CT urogram, now this is a CT scan of the abdomen and the pelvis, so it sees everything. And he's a 69-year-old homeless schizophrenic with unknown past medical history. So you best believe we're going to find some abnormalities on this CT scan. And when we do, that's going to lead to more referrals to more specialists. And so the cascade continues. And that is a part of my moral dilemma. I see it. I am a part of it. And I am, I try to counsel patients best I can. I try to follow the guidelines best I can as well. And it is when following the guidelines and what I feel is best for the patient are two different like decision pathways. So it's that is the moral dilemma. And I was thinking maybe that's why I failed, or that might have contributed. That might have contributed to me failing the oral board exam, because in order to take the oral board exam, you need to have practiced for at least a year and a half. So I was already practicing for a year and a half or so, and I everything on the oral board exams when I took it seemed, I mean, of course it was hard, but I didn't think I failed it. And but I wonder if because the way I practice is many times different than the recommended guidelines, because I'm trying to tailor the practice to this specific human, this specific patient. And but that's not what they want on the oral board exam. They want you to follow the guidelines, and that's what I continue to remind myself as I study for this oral board exam next month. But yeah, that's my moral dilemma, and that's really everywhere. I don't only see it in my practice of urology. I mean, I see it everywhere. I see it everywhere. There's so many moral dilemmas. Look around. It's 2025, and I do my best to do my best. That's all I can do, and not everything's okay, and that's okay, because if it's not, then that means I'm not okay right now, and I'd rather be okay right now. So I will say that everything is not okay, and it's okay. The paradox. All right, y'all. I don't know if I'm actually going to upload this one, because this one feels more feelsy, and I get scared because as a professional, you're not supposed to really feel like, and I'm not even board certified yet. All right, y'all. Well, we'll see you on the other side, and catch y'all on the flip side. This is Dr. Tonthat, and we are now timed in.